Good morning. I'm Samir Mehta and welcome to the Complex Coronary live session. Today is the third in our series of the webcast. The previous two cases, the first one was a left ventricular assist device performed with the Impella catheter. The second was a trifurcating LAD, diagonal and septal. All of these have been placed on the archives. I encourage you to go back into those and take a look. There is a three-part, almost a perfected CME session there. You can get a wonderful didactic on the specific topic by Dr. Sharma as an introduction, which is replete with all the clinical trials which are relevant to the subject. You will then see the live case as well as numerous questions that have been carefully answered by Dr. Sharma and me. Hopefully you will find that a very useful review. For this morning we have another exciting case of an elderly male with the calcific left main, in which not only do we want to show you some specific techniques how to deal with such a complex case, but also demonstrate to you the new 7 French Datascope sensation intra-aortic balloon pump. So without any further ado, Sameen, good morning. Looks like you're all ready to go.
All right. Well, good morning, Samir, and good morning to all our listeners and participants. And I welcome everyone for our third live case series. And this patient is an 88-year-old. If we can just start with the slides of the case. It's an 88-year-old male who presented earlier last month with non-STEMI from the right coronary artery. He actually, since then, we did a PCI, and he has done well, except some still have exertional shortness of breath, but no angina. He has risk factors as shown there. He had a history of prior PCIs in late 80s and 90s and has done very well until presentation last month. And he has been on aspirin, clopidogrel, rosuvastatin, and metoprolol. Now, he had a cath on 8/11, which revealed 3-vessel disease and left main with an ejection fraction of 35%, largely because of moderate to severe inferior wall hypokinesis. He had a left main of 70 to 80%, distal bifurcation, and mid-LAD about 60%. Circumflex few branches, 1 or 2 branches are closed with a bridge collateral, and RCA was 95% calcific osteal lesion, which underwent PCI. We did a cutting balloon and put a Zions V, DES, and now he is here for the intervention of left main. As you know, the left main is a big issue in terms of whether should undergo surgery or should go for PCI, and that will be the focus of our discussion today. Now, case basically, I wanted to just show if we can go to our angiogram. This is always when patient comes back, we try to see the vessel which we have intervened, and starting with the groin pictures because of the suitability of the closure device and any surprises. Many of these patients will have, beside tortuosity and calcification, disease also. And this we've injected both sides, left and right, as you can see here. Very tortuous vessel, but otherwise no significant disease. Now, this is the LV, which has actually improved. It was about 35% last time, and it looks about 40. Inferior wall is still hypo. We just take a picture with the diagnostic catheter and EF around 40 plus. The right coronary artery, as you can see here, the stent and the ostial RCA and proximal RCA looks excellent. Which is very reassuring, and we expect that. You know, rarely you will be surprised when patient comes back that they have little restenosis at the edge or maybe a dissection. Now, this is a vessel in question. Now, you can see here a lot of calcium in the distal left main and translucency. You say, well, it doesn't look like a tight disease. In this view, the patient's creatinine with 88 years of age, creatinine is 1.3. And is therefore its estimated GFR is 52, so that make it a CKD of 3 only. But you know, we try to limit the dye. We had done a pictures in the past, but clearly the bifurcation, calcific disease, and this becomes very clear in this view. You see that in AP cranial, very significant kind of bite into the distal left main. Therefore, this is the basically question, what to do and how to deal with this kind of patient with a left main, and usually it's a multidisciplinary approach in any institution, knowing that left main is a surgical disease. We also at Sinai, we collaborate with our cardiothoracic colleagues that any left main, even they are referred to us, we discuss with them and make a collective decision. Having said that, if we can go back to our slides, and I'll just present some background and then we'll come back to the cases. Go to the next slide. The most of the left main basically are the distal left main, like in this particular case. 2/3 of them, many series have 80+%, some about 50, but majority of the left main series has shown the distal bifurcation is the most important and is the most common. Next. And you know the earlier data of the left main PCI having a bad results of balloon angioplasty in Hartzler era in late 80s, that, and of course the success of coronary artery bypass surgery in this group of patients, because early trials like VA Medical Center and CASH trial, when they initially started against medical therapy, left main during the course of those randomization became selectively treatment approach being a bypass surgery, because patients on medical therapy were not doing well. So that left main kind of became a surgical, established surgical disease. But then we have numerous reports. Actually, this field, I would say the credit of the left main, you can call it a father of left main intervention, being Park from Korea, that he started this, that why can't we put a stent in the left main? It started with a bare metal data and then of course extending to the drug-eluting stent, and now we actually have numerous reports of high procedural success and sustained long-term results of left main stenting in the era of the DES. But if you go to the next slide, and that is, but even now, in 2005, the PCI guidelines categorizes unprotected left main as a class 3 indication. That means it should not be done. Now also, little disappointment that recently we had, next slide, the appropriateness of revascularization of advanced CAD. If you see on the right lower corner, isolated left main disease or isolated left main with coronary artery disease with any category, whether it's a ejection fraction normal, diabetics or low ejection fraction, is inappropriate. So that now, anytime we try to do a left main intervention, we need to know as an interventionalist that we need to prove that yes, it's something which we can do it safely for a long-term benefit of patients and we are not harming them, because our appropriate guidelines all mention that left main being a significant, the adverse factor for PCI. Next. And therefore, issue became basically the success. I think acute complication, stent thrombosis, we have been able to over with it because of techniques, excellent results. Restenosis, TLR, sudden death, again, part of the routine angiographic follow-up for these patients. And biggest issue remains is the long-term follow-up against coronary artery bypass surgery. Next slide. Coming back to the point of the distal left main, that how do you deal with it? There are various approaches. Simple is one stent approach. That is, that you stent, particularly if there is not a significant disease in the circumflex, you use one stent only. And that is a crossover technique which we talk. And of course, it can be others being a kissing stent technique or the crush or side branch access followed by dilatation, T-stenting or culotte, basically putting two stents together, but various approaches. But therefore, based on the individual lesion morphology, we need to decide which technique to be used. Next. Now, this is a little busy slide, but it's the era of the bare metal stent. And overall, disappointment was that we have almost 20 to 30% MACE rate and restenosis with a bare metal stent. Next. And therefore, now we actually have a 7 non-randomized publication of the DES in unprotected left main. And you see the red highlight I have, that percent of patients with a bifurcation lesion. Reason being is that outcome of the left main basically depend where the lesion location, whether it's the ostial or body, which do very well, or it is in the bifurcation, which actually, as you can see, almost 70 to 80% lesions are bifurcation in all these series. But that leads to the TLR and TVR of about 6 to 10%, except the one report by Tierstein, by Matthew Price from Scripps, does have a bad outcome, but most of the reports are very encouraging of treatment of left main with a drug-eluting stent. Next. Now this actually is the earlier publication with the sirolimus eluting stent from Park, showing that importance of the body location of the DES with bare metal. You can see here that ostial and body, once you have a DES, it's 0% follow-up TLR. It's only the bifurcation which remains around 8 to 10%. Next, we actually have the similar data at Sinai. We presented with our 100 patients initial analysis that comparing the DES 50 DES patient with the BMS 27. Now we have 100 patient data that's showing that it's the distal bifurcation. The DES patient do very well with the appropriate treatment and with the restenosis rate of about 5 to 8%. And of course, being a high risk because of comorbid condition and high Euro score, some mortality do occur in these patients. But basically, the data are that acutely we can have a good results of intervention. Next. Now, this is just to highlight the importance of location, lesion location. This is the multi-center registry, data of 147 patients with the ostial left main and non-bifurcation. And you look at it that at follow-up of 2+ years, that we are talking about a restenosis rate of 1%. So it's very, very impressive in terms of the non-left bifurcation, left main having a very low restenosis. Next. And the question also comes, what if the BMS, knowing that we don't have a large DES, but we have a randomized trial from Australia of 100 patients, with every patient had an IVUS and cutting balloon, followed by DES or paclitaxel, and shown that, yes, DES, despite a smaller final lumen diameter, was better compared to bare metal stent. Therefore, I think although the data from main compare by Park still make us believe that BMS may equally be good, but I think overall advantage of DES is because of lower restenosis. Next. Now we actually have, besides observational data of the Park and from Cedars and TUFO and Colombo, the 2 randomized trials, Lemans and the Syntax. Now, Lemans trial from Poland and many other investigators has shown that about 110 patients, with half of them with PCI and the other half under cabbage, that lower acute MACE rate, MACE of 30 days, and also at 1 year, actually, the MACE event-free survival become not different between 2 groups. But important point was that PCI resulted in a better improvement in ejection fraction. Now, clearly that this trial has been criticized largely because that the Lima for in a surgery patients was used in only 72%. So it may not represent our run-of-the-mill the treatment of current cabbage, which actually leads to next slide, which is the Syntax, which evaluated left main with or without multi-vessel disease. And we know the data of the Syntax MACE in terms of the death, MI, stroke, and revascularization, that overall PCI in an entire group of patients did identical for the death, MI, and stroke, having a lower stroke in the PCI group and slightly non-statistically higher MI rate in the cabbage group. But MACE overall at 1 year was in favor of cabbage largely because of repeat revascularization. Of the subgroup of the left main of the 700+ patients, you see the overall, the 15.8 in the PCI and 13.7 in the cabbage. Statistically not significant. But more important was that just to what I have mentioned here, isolated left main or left main with 1 vessel disease, you can see the height of the red bar versus the blue, that basically the PCI did non-statistically better. It's only when your left main with multi-vessel disease comes in, 2 or 3 vessel, that cabbage becomes superior to a PCI with the overall outcome shown in this slide. Now, we actually have the latest, the 2-year data, which was presented last week in European Society of Cardiology. And you can see here that even at 2 years in the left main on the right side, the death, CV, and MI, very reassuring that remains identical, not significant. And of course, the revascularization was the basic difference which drove the MACE in favor of cabbage. But overall, the message what we learned, that correctly placing drug-eluting stent in this day and age is not associated with adverse outcome, except the price you pay is the revascularization. Next. And of course, this goes back to the Syntax score and kind of the same which I showed earlier, the left main with the multi-vessel disease, that really the cabbage, in my opinion, should be reserved patients who have left main and extensive other vessel disease. Next. And therefore, now question comes that you have various approaches, how you are going to deal with it, whether you use one stent or a crush stent or kissing stent technique. This kind of a simple algorithm that if which can translate, this is from Park, I put it very simple way, that if you have an insignificant disease of the circumflex, then you put a stent across. Very simple. Next slide. But if you have a significant disease of the circumflex, large crush or T stenting, that if significant circ, but circ is small, but if there is a large left main and large circumflex, then you put a 2 kissing stent is a right approach in these patients. And this is the various techniques, and we'll talk about it. With that note, I think we are ready to start here. This patient, which in question, 88-year-old, which we are ready to start with the intervention. This not unusual. These patients start oozing, and we can go back to the live. Actually, now I can introduce my associate, Dr. Keeney. We call AK, and with my rest of the staff and the fellow here, Atul and Fernando, and we'll be starting then show the demonstration of the new intra-aortic balloon pump, which is 7 French, called Sensation. And AK, you want to just take it over from here?
Yeah. We just have the 7 French Sensation of the data scope, which is right over here. It comes with the 2 kit. Actually, we already have the sheath on the left side, but it comes with the needle, with the sheath, and the wire, which is for the sheath. But the great thing about this new balloon pump is we can use it sheathless. And what is different compared to the previous balloon pump is that the wire is different. It's 018. It was 0.026 in the past, and this is a 7 French, so we can use sheathless. And now what they have done is no need for an A line. So faster preparation. We have this optical sensor. So without preparation, we can just give it to the tech. Because of that, what happens is as soon as the balloon pump is in the body, it automatically calibrates, and it keeps calibrating every 2 hours. And because of this optical sensor, also the waveform is very crisp and clear. So this is the advantage compared to the previous. And the most important thing is that we can do it with a smaller sheath size, and with the catheter, it's a wire that we have right here, we can do it sheathless.
Yeah,
and the sheathless is
you don't have to do a much pre-dilatation or making an incision. I think to me that's a big advantage.
So we have a 5 French sheath, just going over with the wire. The anticoagulation has been with the Angiomax. We have an ACT of 320. Just go on the fluoro. We have the wire already there.
Yeah, I think it's a miniature. In the past, we always used to worry about balloon pump causing vascular complication, and largely that was because of the sheath. Put the wire back. Yeah. Good. Now, the sheath, I think, still should be used in some patient where you're giving 2B3A and a lot of oozing. No, one second. Slippery hand. Good. No. Yeah. Go. Should be able to go? No? You want to dilate with the dilator first?
Okay, maybe.
Yeah, we can dilate. Sometimes just maybe use a dilator, 7 French dilator before inserting.
And the other thing which has become quite clear is the level of calcification which we have started appreciating in the coronary tree. The advantages of, I think, a lower profile balloon pump clearly are obvious. I have always looked at whether it is placing a balloon pump or impeller as truly the real challenge is always a vascular one. And Samin, as you do that, one of the questions which has come up is that in your specific patient, you have highlighted very nicely the importance of having a close collaboration with the surgeons. But in this particular case, was surgery not considered because of the age?
Yeah. Exactly. I mean, particularly the patient preference also, and we felt this one actually is the patient preference. Clearly, the bifurcation, as you pointed out, that first choice should be given as that to be for the surgical point of view, that the PCI could be done in high-risk patient. In this patient, maybe because of age, but more importantly, the patient's personal choice, patient being and knowing that he has done so well with the PCI for last 20 plus years, and we actually gave him option that he comes back. We needed to do a PCI when he presented with a little hypotension acutely during STEMI, but many of these left main patients we are done, send them for cabbage later on, that do a acute MI PCI vessel and then send them for, refer them for cabbage. But this patient's clear-cut choice, not going for surgery, led to the decision of bringing him here today for PCI.
Okay, just once we have the balloon pump in the body, as you see it, I think a negotiation was very easy. And because the lumen of the balloon pump is so small, just before connection, you withdraw, make sure you have the blood to fluid connection. That's good. And once you are connected, the great thing about this new pump is that you don't have to worry about thrombosis once you're connected it to the fluid, because the lumen itself is so small. Because one other thing that we used to worry in the past, especially the patients are going to ICU and you have a connection, people try to draw blood and do all kinds of things from the lumen that is available, and we used to have cases where it used to clot or be the kink in the balloon, which we don't see it in this new low profile balloon pump.
Anu, you're sheathless at the moment?
Yeah. We are sheathless, and we can just show here at the groin, it's nicely sitting, no ooze around the balloon pump. This is, we have an ACT at 320.
Do you see any reason with the 7 French sheathless balloon to ever go back to the 8 French after this?
It will not go to 8 French. The question only comes very rare cases, especially in emergency situation, acute MI, when we have given 2B3A, and if we are seeing ooze around the balloon pump, that's the only time we have to think, would a sheath be necessary?
Perfect,
but
yeah.
Other than that, in elective cases, for a support like we are using now, I think it's a good thing to do it sheathless.
Okay, now question, actually there could be another question here, is that why do you need a balloon pump? I mean, I think that the answer there would be that now LV has improved quite a bit. It was 35 before. That's that range, in my opinion, when you're doing a complex stenting, and like this case will be calcific. And that is the reason we selected that, you need to, as an interventionalist, if the procedure is not may not cause harm. Like if somebody has a severe PVD, you may say that, I should not put a balloon pump in this case. In this case, it's not a PVD, that balloon pump will support during complex intervention, particularly the rotablation we may have to do of both branches, definitely the LAD, because of such a heavy calcium, and will allow us give enough time to have a good interventional result. So that will be the reason. But can you do this case? Particularly this particular patient where AF is now around 40 plus without balloon pump, I would say yes. But just knowing that the decision was made beforehand that using the balloon pump, I think it's not wrong in this particular case. But yes, it can be done otherwise also. But it's reasonable to just go with the balloon pump in this particular patient, gives you support during intervention.
In the meantime, for our viewers, please keep emailing your questions to me at info@ccclivecases.org. Samin, what are you really using as your underlying criteria where you're trying to decide between balloon pump versus left ventricular assist device such as Impella?
Well, I would say I think to me, like cutoff is about 25. The ejection fraction of 25 is the nice cutoff. That is anything less than 25. Vicky, you want to give a little medicine to the patient? Once you go to a less than 25, it's at that point go with the Impella device, and more than 25, just use a balloon pump. If EF is more than 50, 45 and 50, then probably even in the complex case, you can do it without balloon pump. Clearly, when we are doing the protected left main PCIs in the past. We used to use a balloon pump in almost 60-70% of cases. Now overall balloon pump use is about like 22, and in the left main intervention, and in the patients with the assist device in about 2%, 2 to 3%.
Anu, what is your anticoagulant strategy for this patient?
He's on Angiomax bolus and drip. With the initial bolus and the drip, ACT was about 280, and we gave a half bolus. Now the ACT is running at 320. Now, because of the heavy calcium, we have decided we are doing rotational atherectomy, and in the elderly patient with a unprotected left main, we would like to have a pacemaker. So you see that there's a temporary pacemaker. I'm trying to see if I can wire it directly without any other balloon support.
Yeah, many times, you saw that kind of ulcer in the distal left main,
Well, the AP cranial view clearly demonstrated that. Now, this is a 7 French based system you have?
Yeah, this is a 7 French that even if we decide to put a 2 stents, that will be able to go without. We are ready with the. You need to be a caudal. You will not be able to see it here.
Well, much better appreciation of the calcification in this projection.
Sure.
No, show me some dice on exactly.
Okay. Yeah. And then particularly the distal left main, the LED comes at an angle. So that and we know the rotawire has that limitation, will not be able to make that upward turn. Therefore, it's a reasonable, rather than you try and damage, it's easier, take it out, go with your over-the-wire balloon and then switch to the rotawire. Whether over-the-wire balloon or you want to use a fine cross is the choice. But in this case, it's not an issue. Fine cross probably is the good for patients where or any of the transport catheter in patients who have total occlusion. But otherwise, just 1.5 over the wire balloon, and then use your workhorse wire. Now, this is which wire?
Run through.
Huh?
Fielder.
Yeah. Okay.
Fielder.
Yeah, that's good. One second.
It's a very sharp angle, the origin of the LED.
Give me a torque. One second. Good. Just hold it there. Yeah. Okay.
There you
Good.
go.
We are okay. Now let's see. We are in the LED or no? They're in the
Subtle.
LED. Yeah, that's okay. Now we need to just go to AP cranial. No. Will die. It's in some high lateral. Will die.
They are in the LED.
There you
Die.
go.
Good. Okay. Keep this wire. Okay, therefore just to emphasize that even the lesion may look simple and you think we will be able to do rota, but just don't persist. There is no reason for to continue persisting when you don't have a results. That just quickly switch to your the regular technique. And this is what we have done here. Was it wrong to try the rota wire? I would say no, because majority of them I know that we could do without going to this switch approach. But yes, we gave it a little try for a few seconds. If not, then we switch to now this is the rota floppy. Very rarely we'll use the rota extra support, particularly if there is an issue of the support or osteal RCA. But otherwise, rota floppy is good enough. Now, question is what should be the burr size? Knowing that we usually do intervention and atherectomy, just one burr approach, and that using a 1.75 in this particular case, where the vessel is about 3 point, osteal LAD 3 point plus millimeter is a reasonable approach. Keep going. Now, can you do it without rota? Well, I would say that this is the calcium. I mean, clearly that I would even have a hard time that I could that there is about 15-20% chance that if you try the rota, the IVUS will not even go. Therefore, if these calcific left mains, once you try to do them, it has to be that good lesion expansion and stent expansion, the lesion compliance, so that rotational atherectomy, one bar. Now, knowing that the predominant calcium is in the LAD area on the superior surface, that it just go to the LAD and the circumflex can be done just by the cutting balloon and so. Okay.
Okay, we're going to check the speed outside the body. About 155.
Good. Okay. About slow speed, irrespective of the bar, about 150, 155 outside, and about that will translate to 140, 145 in the body.
Excellent.
Now, the burr can be advanced as a single person approach, but it's better to pull, push so that the guide does not come back and forth, and no dynaglide going in. Remember in the past, we used to do a dynaglide going in, but absolutely that should be discouraged. There's no reason for us to go dynaglide going in, coming out, yes. Let me pull the wire a little bit because it's in the small branch.
Diagonal branch, yeah.
I think once we start burring. Okay. So the 3 important steps again. Just release your knob. Make sure you move it backward, forward.
Show this one.
Yeah.
Release the knob. Move backward, forward, so any tension between the sheath and the burr is removed. And then under fluoro, you see that the burr is moving on the wire. So any tension between the burr and the wire is gone. And the last, once you've done everything correct, you just give a tap on the dynaglide and you see the burr never moved. Even if doing the first two, if there was still any tension in the burr and the wire, if it jumps at the speed of the... Now we're going to start burring. Because it's distal left main, I'm going to start just coming out of the guide, almost at the ostial left main with the same slow pecking motion. Because it's eccentric, we already see that the burr is cutting at the upper surface of the lesion.
I think that's
and
done.
Once you're done, when they say 20 seconds, you just stop. No burring more than 20 seconds. And we've done the burr. We're just
polish
going to
a little bit more or no?
Okay.
So, I mean,
Let's do a little more polish, yeah.
How is the patient tolerating at the moment?
So far, good augmented blood pressure of 140 and non-augmented about 110.
And not using the pacemaker.
Now, the pacemaker, for the other indications besides the dominant right, we actually have seen some patients when we are doing a rotablation of the bifurcation distal left main or ostial LAD, that it does cause asystole, so that we do routinely place. Now, if I am doing this case without rotational atherectomy of the left main, I will not put a pacemaker. The pacemaker is just because of that we are using the doing a rotational atherectomy.
Anu, I thought that was a very nice illustration how it was critical to start ablating right outside the left main and how you came out with slightly with the guiding catheter. I think that's one of the take-home messages. I was actually quite surprised how nicely it made the angle. For a moment, I thought you might even have to step down to a...
Now we can remove the rotor. Now we can actually say that this is the picture now. We know that in eccentric lesion, rotational atherectomy maybe just will cut on the superior surface, which is fine. Our goal there is that as the lumen has, as long as it has opened up the interelastic lamina, and here you see the distal left main definitely looks much better than before. There is no need for us to go to any other view, but we clearly see it here.
Give me another one. Fielder.
See the ostial nicely open. Good. Go. Now we are going to put 2 wires, one in the and go accordingly. That we have. Yeah, good. That's okay. You want to put this? Now I expect that the wire should be able to go now. Yep. Good.
Now this is the run through wire.
Now this is the run through in the LED. Now actually we can remove the rota wire. You don't need 3 wires in the body, and we are going to put 1 wire into the circumflex.
What wire are you using for the circumflex now?
Sir, just because they are 2 different. Basically the side branch we go with the fielder. In this particular case, it's a fielder. We'll use for the circumflex. That's what we use for the LED to cross it and exchange over.
Now the pre-dilatation strategy, we have a 3O Voyager, 3015 Voyager for the LED, and decided the cutting balloon of the circumflex.
So the real criteria which you are using to differentiate between the cutting balloon and the rotational is the ostial and the non-ostial location plus the calcification?
Calcification,
yes, yeah. And most important to me, I think the ostial side branch is a very important, and in this particular case, since we have done the good rotational atherectomy, we can use a high pressure balloon, short high pressure balloon into the, balloon into the LED, but circumflex, knowing that it's very important that a good expansion occurs and using the cutting balloon for that purpose. Now, can you use the same cutting balloon for both? Yeah, we can do that also. So let's see once we go through, we have a 2.5, 2.75, 3 what cutting balloon we have?
We have a 2756 cutter.
Good. Get a 2756 cutter. That's good.
Does that, Samin, leave any room for the angiosculpt?
Well, I think what angiosculpt is a good device we actually have used quite a bit. Good. And to us, more so, the angiosculpt is in cases where the instant restenosis, but otherwise angiosculpt also is used as an atherectomy besides the cutting balloon. The only disadvantage, I would say, that in majority of wire came back. That in what we have seen is that in many patients, that angiosculpt, we really did not get the ostial dilatation. Some we were surprised to have excellent results. In some of them, we could not have a good expansion, so that by default in our lab actually, right or wrong, that we just use a cutting balloon as a default ostial expansion, and sometimes if we cannot expand it, then we may change it to the angiosculpt, and angiosculpt is routinely used for instant restenosis in our lab.
Samin, I have several questions which have come in the meantime. Let's try to take some of them. The first one is that I'm quoting you exactly as it has come. His LPL is occluded, RCA is large. Would it be reasonable to stent across the LED after cutting balloon of circumflex than using a bifurcation strategy?
Well, that is absolutely, we actually discussed about, and that's what Anu wanted also. They just put one stent across rather than going through this, because there is a very little gain in terms of the circumflex territory. But the circ does get bridge collaterals, and just for that reason we'll decide. But yes, it's a perfectly clear approach. And now the purpose of that, many times, go a little proximal now. Proximal, yeah. That the purpose here is, from educational point of view, that just to show the different technique, maybe the region, just to say that various steps of kissing stent technique and so. But yeah, if need to be done, this will be the good case of the stent crossover, knowing that yes, circ is the disease of the ostial, but there is a lot of downstream disease in the circumflex, so that less area is supplied by, in this 88-year-old male who has a RCA, which is very good now, and circumflex just represents the moderate territory.
Well, this is the relevance and the beauty of all these questions coming in simultaneously. 2 more questions regarding the rotational ablation.
Okay.
Has your use at your institution of rotational ablation increased, decreased, or it is the same?
Yeah, actually, initially when the DES came, the rotational atherectomy, before DES we were using in about 13%. And initial DES, when it came, it became about 8%. Over last 3 years, the rotablation use in our lab is about 6 to 7%. This year so far we are about 7%. Now, these are the cases where angiographically we decide based on like this case where there is a calcium on both the surface of the vessel. That's the criteria. We rarely will decide based on the IVUS, but angiographically, like this particular case, that will use a rotational atherectomy. This is the 10 atmosphere. For the circumflex, I went 8 atmosphere. So it has been constant, I would say, a few millimeter further, approximately. That in our lab is about 6 to 7%, which of the 450 PCI translate into about 40 to 50. And that's a good for the fellows having a good experience performing around 400 plus rotational atherectomy in the year. But we have 8 fellows, so that everyone has a chance to get a good experience in about 70 to 80 rotational atherectomy. But has been a constant now. And largely, actually, still our number is high, largely because many of the patients are referred for this purpose. That is the reason that in the tri-state area we get so many referrals just for the calcific lesion, and that is one of the important reasons for this high number. In the country, as you know, it's 1.8%. The last data from Boston Scientific is about 1.8% for the rotational atherectomy in the country.
Another related question, have you almost abandoned a step-up approach for the rotational bursts?
I would say that 96%, still some cases, but 96% of the time, in 2 months, we'll have probably 2 or 3 times we'll use a second one. So very, very rare. Good. Now let's decide. You know what, to me, that yes, one stent crossover will be nothing wrong, but you'll see always a little bit of distal disease and so. And therefore, I will, if there is, since it's not wrong to put 2 stents in this distal bifurcation, we'll go ahead with the plan which we had, the putting 2 stents in this case. Now, only question is, I want to prepare the LED a little more before we stent it.
What about the area just before the septal?
No, but that's a mid, the lot of myocardial bridge. So let's just go to the proximal.
Before the septal. Before the septal.
No, we'll leave that. We'll leave that area, which our goal is distal left main. Also, the point is in many of these left main cases, they have concomitant multivessel disease and other areas. Take care of the left main. When they're coming back for angiographic follow-up in 6 months, that time you go ahead and take care of other areas, and that is what my usual approach has been. Therefore, let's get a balloon for opening the LED. A little more. We have trio balloons, some high pressure or no?
Not
what
high
do we have?
pressure. This is
Trio?
regular. Yeah.
Okay, we have 3O15 Voyager. I really want to expand a little more the ostial LED and before putting 2 stents, because for the 2 stent, if you can post dilate, but you want to avoid post dilatation, so that lesion preparation, because recrossing and so, which is okay, but then otherwise you have to put 2 stents again, 2 balloons in those stents and so. So we're going to just open the LED a little more with the 3O balloon. I think the 2.75 cutting balloon has done well, but you probably needed a 3O for the LED. But we are going back with this, the Voyager, 3O high pressure Voyager, and we are going to go with the, good. This will be good. So now it's a 20 atmosphere.
Patient tolerating well?
Patient tolerating very well right now. And see, now it's nicely expanded.
Several questions have started lining up regarding the choice of drug-eluting stents. Particularly, the specific questions are, would it be reasonable to use Taxus or Cyphus rather than Promus or Zymes, which has thick struts and better radial strength for calcified lesions?
Yeah, actually it's a very, very interesting point. Now, I can tell you, for the bifurcation point of view, I have no reservation. Reason being is that the bifurcation, if you're putting 2 stents, let's get out 2 stents, that you're putting 2 stents, which is perfectly
3, 5,
fine.
18.
You don't need to...
18 and 15.
You're 23?
23, yeah?
23.
3, 5, 23.
Yeah, that I would have no problem using a Promus, huh?
LED 3O.
Are you concerned about the balloon overhang there?
Yeah.
Circle 275.
275 or 30. Yeah, therefore, in a bifurcation, I'll go with the second generation. Now, ostial, and this is where it comes back to the very important point, that in the ostial left main, while using a Zymes, we actually have seen many of them, ostium not opening, and we put a cipher inside the ostial Zymes. Therefore, and I know that Abbott is already thinking to do a left main trial, but the stent is not meant for the ostial. Many of the ostials, particularly elderly in America, they just do not expand because the exactly point you made. So in this particular case, what we are going to use it, last time we showed bifurcation with the cipher, and here we are going to show the bifurcation using two Zions stents. Here we are using a 3.5, 23 Zions in the LED, and then we have a 275, 15 Zions into the circumflex.
So, several questions also coming in regarding the use of IVUS. A specific one, would you have planned IVUS evaluation of the bifurcation for stent guidance?
Yeah, well, actually, good point. The data actually have come up now that particularly in the left main, it makes sense that routine IVUS is a good strategy. And therefore, we actually have not been following that approach, but I think it's a clear, good data to support that using the IVUS as a final, as a final pullback.
Okay, this is, I think, just to show how we are going to do the kissing stent technique. We have placed the two stents. Normally, we would say the side branch, which is more angulated, whether you are doing the circ, the diagonal, the OM, RPDA, anything, you do the stent in that particular vessel first, and then the vessel which is the main branch, usually the LED. Here, like we saw, the ostial LED is coming at an angle from the left main. We place the LED stent first, and this you see is the two dots at the distal left main, which is a V, and now I'm pulling back both of them same time.
Yeah. So put the circ a little bit more and make it a dot identical. So they're okay. No, not that much. That's good. Advance the LED? No, too back. Yeah. Advance the LED stand a little more. You need to go further. Good.
No, maybe pull back the LED.
Yeah. So go with a little more. So basically the key is that you need to go, this is the circumflex. Yeah. That both should be identical. No, you have to advance the circ inside. We are too proximal. Good. Hold it. Okay?
Yeah, perfectly aligned there now.
Yeah, we are okay now.
Yeah, go on. So we are going to go with the 8 atmosphere with both of them. Now this is the time, if you need a balloon pump, this is the time. And let's see what happens here. 8 for about 8-10 seconds, negative.
In the past, you used to go 10 atmospheres here.
Yeah, but just because of it's a Zions, and I will be a little concerned about 8 to 10. Actually, by the LED, I went to 10, and the circ expanded. But more important now is that I'm expanding the LED. Now again, that usually with the cipher, we'll go to a 20 atmosphere. Here, I'll never go with a Zions and so more than 14 atmosphere we learned. This is 14 atmosphere at 3.5, 23 Zions. So I'll go negative quick because this is, so far patient has tolerated, blood pressure is still augmented about 120, does have some ST depression, but will be transient. Now you go to the third step is about 12 atmosphere for the circumflex, while our LED stent is there, so that, many times it looks like it's a crisscross, not to worry about, negative. And then last one, go back again at 10. Go. This is the fourth. Now you can, and I'll show you these two pictures, negative. Simultaneous inflation, simultaneous deflation. That this is now how the stents are expanded after the individual dilatation. And if you go back, when we did an initial, look at this, that it was not expanded. So there is a clear-cut difference that how it comes with the serial dilatation, nice expansion. So once it has been done, the whole point will be the guide as much as out, and we take both of them out and see. Good.
So, questions about abscessimag. Did the patient receive any bolus?
Yeah, we actually, you know what, this is a good case where you should use 2B3A, but just because of the age, we are little, the wire may have crisscrossed a little bit, which happens sometimes, that we may decide if everything looks good, not to give any 2B3A, but yes, in many of these cases, it's reasonable to use, let's take this out and then we'll decide. It's out anyway. Yeah. Now, that's why, one at a time, many times when you try to take both of the balloons out, it happens the wire are crisscross and may pull another wire, but as long as one wire is there, we may not need anything further. Yeah, you want to pull back the wire? Pull the wire, yeah. Good. But yes, I would say that 2B3A in our lab, in this particular case, despite using angiomax and patient is on Plavix, should be done, and any of these unprotected left main. We actually have already tested this patient for the Plavix resistance, and he is 52% inhibited. So the Plavix is working. Clearly in this left main cases, high risk for stent thrombosis, that until you switch to prasugrel, which we don't use yet, but this kind of case we'll definitely check for Plavix resistance, and if it is low, either you can switch to prasugrel or you can make it a double dose of Plavix. Now this is the case, it's a fully responder for both aspirin and Plavix, the wire injury.
I mean, is there something distally you see in this?
It's the fielder wire which we were thinking that could be.
Yeah, therefore to cut down the angiomax now, and that's where the answers, anytime you have this wire-induced injury, and we actually, our paper has just come out, that in those cases, that just stopping your angiomax, that is what you need for the wire perforations, and it just does not grow up, and you will see, while in few minutes later I'll show you, that will completely stop, and this is where it has fully expanded. We got to actually few minutes, we can do a quick one. I was in one of the branch.
Now the question goes back to 2B3A use. This is the main reason also in any complex case that we never give 2B3A, except it is ST segment elevation MI, where you know the benefit is. We know the benefit of 2B3A is that you have given the 2B3A before the procedure, so the platelets are well inhibited. When we are doing any complex cases, for two reasons. One, this kind of a wire-induced wire perforation which you normally see distally, and the other thing is also vascular complication in this elderly patient. To avoid that, we don't give it until the end of the case, and we are happy that we don't have either of the two. No evidence of any vascular complication or wire-induced like here in this patient, though we have 2B3A here with us in the room, we are not going to use it at this time.
Well, fortunately, it does not look to be increasing, nor there appears to be any major hemodynamic compromise.
Usually what happens is many times it's just a little wire hematoma.
Right.
Well,
the question comes, at what level do you decide that you need to put in for a prolonged balloon inflation at the
I think this kind of case will not, even if you'll be off the line from our point of view, that will not stop here. This patient will be watched in the cath lab for another 10-15 minutes. And if that remains fine, and maybe Anu can update on this paper which just came out of a role of angiomax, particularly that how this wire perforation had behaved in this era when we had a wire perf, not the stent or balloon perf, that wire perf in the patients who were on angiomax versus what used to be on heparin. And Anu, you want to tell us about?
Yeah, what we actually, it came out, we started noticing when we were doing the procedure, when we started initially with angiomax. Always the belief was that use heparin, because once you use heparin, if you see this kind of things, you can reverse the anticoagulation giving protamine. But if you go back to the pharmacokinetics and dynamics of angiomax, you see how it is, it binds to the thrombin. It binds, but at the same time, it is irreversible, means as soon as you stop the drip, it cleaves from the thrombin, and that is why the thrombin is then free to form the clot. And that's why what we started noticing that when we were doing especially chronic total occlusion and this kind of complex cases, this distal wire perforation, which we used to see what we called as a myocardial fan, you see that they close on their own within 10 to 15 minutes. Initially, in the beginning, we used to get worried about put a small balloon and watch. But a couple of cases later, we noticed do nothing. If you just stop the angiomax drip, we used to stop seeing that this kind of distal wire perforation compared to, and also subsequently the need of the pericardial effusion, because of the worry about these things is tamponade has been very low with the use of angiomax.
So unless the patient is clinically showing signs, you would not get any 2D echo or something?
No, not in this situation. We have done it in the past when we used to see this with the angiomax same. We used to get worried, how are we going to reverse this, and watch the patient for half hour, 45 minutes, multiple echoes in the lab, and we have seen that usually they get better.
It looks like that's a small branch, and this is the disadvantage of these the fielder wires and hydrophilic. They're very good to make the angulation, but from our interventional point of view, patient is doing fine, good blood pressure, and usually it seals by itself. We stop the angiomax. As again, not being cavalier about, we are concerned about this, so we'll watch this patient another half hour in the cath lab, and now we are having probably over about 40 or 45 of these wire perforations on angiomax, and that's nothing more was needed in these particular cases. Now, having said that while we are going to show maybe in the end, if we can go back to the slide, so that I just go back and knowing that we have about 3 more minutes left, if we can go back to the slides. And just go back, make a point now, summarize. Where's the camera guy? Yeah, no IVAS. We're not doing IVAS right now. Then let's just come it up. We'll do the IVAS at follow-up. We are going to wait a few minutes in this case anyway, so that just to take the take-home message, that left main stenting with drug-eluting stent, that many studies have now shown the feasibility and safety of left main stenting with DES and MACE outcome up to 2 years in patients as equal to CABG in the majority. That except the patient with the high syntax score, the CABG versus PCI using a Texas DES has been equivalent. So that yes, high restenosis, but overall the MACE point of view and biggest concern in the past of the DES of the left main was death. And that actually, in my opinion, for the 2 years I have showed that with the data now we have the syntax in the 700 plus patients, that very, very reassuring. Second, optimal technique, strategy of stent deployment and position clearly remains crucial, that you have a good deployment like we have shown in this particular case with a bifurcation stents and so. And in many patients, a single stent crossover has shown to show excellent long-term outcome. Next, so now who should get that DES for left main? I think if I sum it up, PCI is preferred. But again, with the clear-cut grain of salt, there is presently a current class 3 indication, the lesion in the ostium and mid-shaft. We know that has a restenosis rate of 0 to 1%. Distal bifurcation lesion with one limb is disease-free, means crossover. You're putting a one stent across, it's perfectly reasonable that it should be, you could do a stenting in these cases. And lastly, the distal bifurcation lesion involving the both branches in a patient with significant comorbid conditions. These are the surgically high risk, which is currently class 2B indication. So that these are the patients, in my opinion, should get a left main intervention stenting. Now, who should get CABG? Clearly, that is strongly indicated because it's a class 1 indication. And therefore, anytime you have additional total occlusion of the left coronary system and you are working with the left main, in my opinion, should go for surgery. Severe concomitant multi-vessel disease, especially calcific and syntax score of 33 and above. Clearly, that patient belongs to CABG, not to PCI. Heavily calcified distal left main. And lastly, intolerance to prolonged antiplatelet therapy. DES is as good as they can take a antiplatelet therapy. So that particular case, if you cannot do it, they should go for surgery. So putting back to the last slide, this is my personal view point, and hopefully that is the column on the right lower of the isolated left main with a diabetic and multi-vessel disease with a normal EF. I think it may not be until we show good randomized trial and long-term data that not inappropriate becomes under equivocal or just undeterminate. And that clearly that maybe in the low ejection fraction, question remains for the left main, and particularly as long as the syntax score is less than 33. Next, and that's the last one, I just want to sum it up. Basically, that I hope to see that that soon we'll have a PCI update from ACC/AHA making left main PCI as a class 1, maybe for isolated osteal lesions, or 2B or 2A in other subgroups, and keep class 3 only for syntax score of more than 33. We definitely need, from interventional perspective, and I think the syntax, I support this based on the syntax data in our patients, that the left main is safe. It may prices only repeat revascularization, but not the mortality and overall MACE.
So, I mean, two quick questions. One is there a need for surveillance angiography? Are you bringing these patients back routinely, or you've given that up?
100%. That all patients will have based on how the left main results were and how many other vessels left behind, I will give a 4 to 6 month follow-up. In this particular case, has some mid-LED disease, I'll probably make it a 6-month angiographic follow-up date in this particular case. We'll go back home tomorrow with a clear-cut point to the date to come back for the surveillance angiography.
Just by looking at Anu's and your demeanor, looks like the patient is quite comfortable and that there is not any major concern about the wire-induced injury and that you're just going to watch it, take a look later, and that hopefully should seal.
And we have actually stopped the balloon pump for last 4-5 minutes. No unaugmented blood pressure 125, that's where he started. No pulsus paradoxus, and of course for the cardiac silhouette point of view, and otherwise from angiographic point of view, if we can just show that this still remains. It may take a little while to completely go away, but I'll just watch him few more minutes. And with that note, it's about 9 o'clock, and I thank my all cath lab staff and everyone and our viewers and Dr. Mehta for this our third live international series.
Samin, I want to thank you and your staff. Anu, another excellent case, superb demonstration of a distal left main, a truly complex lesion, the very nice use of the smaller new intra-aortic balloon pump, which is sheathless. For me, I think it was even more useful to see somebody else going through wire-induced trauma and taking care of it, but overall excellent demonstration, and I thank you and your staff. And I also want to tell our viewers that case number 4, series number 4 would be October 20th, Tuesday, 9 in the morning. Thank you all for viewing, and do please visit us for the archive cases.
Okay, thank you.